Is that better, guys? Anyone can just let me know in the chat if it's the same. Is it better? Is it? Can you hear me at all? You can't hear me. Settings. If you guys can hear me or if it's understandable, I might just go on in interest of time. Is everyone happy for me to continue, or is it too bad? Is there any objections? So is it understandable enough? Is it better if I speak louder? Does that help at all? I might just speak louder and continue. It's not a lot of content. Yeah, there you go. It's not a lot of content to cover. I mean, I plan on finishing about 15, 20 minutes early, so I think we might be on time, if not still earlier, to be very honest. So it shouldn't be an issue with anyone's schedule. I'll just try to make an effort to be louder, and if I'm not being loud enough, just drop it in the chat, and I'm happy to be loud. So I'm going to share my screen again. Oh, that's nicer on Chrome, actually. Let's share screen to share PowerPoint. Wonderful. And everyone can see the screen, is that correct? All right, the screen. Okay, perfect. I'm going to be using this. I'm going to be using a finger, like a pointing thing, and I hope everyone can see this as well. I'll change it very soon. Any issues at all, obviously, just, I'm honestly really sorry about the delay so far. So moving on. So we're just going to talk about the adrenal axis, and really understanding this will interpret all the investigations that will come for with all the diagnosis very shortly. The only reason the kidney is here is to let you know where the adrenal gland sits, which is on top of the kidney. So 2 kidneys, 2 adrenal glands. And once you know that, you can just pretend the kidney in diagram. So the adrenal is going to be secreting cortisol, and as with a lot of things endocrinology, there's an axis here to control the amount of cortisol that is produced and when it is produced as well. So you have positive and negative feedback. So let's start all the way from the top here. That's your hypothalamus. That's your anterior pituitary. That's your adrenal gland. And else matters. So whenever you do need to produce cortisol, your hypothalamus is going to produce just corticotropin releasing hormone. Once it produces RH, that's going to stimulate the anterior pituitary. So they're going to stimulate the anterior pituitary to produce ACTH. Once you have ACTH, that goes and stimulates the adrenal gland to produce cortisol. So it's sort of a 3-way step. And this is quite important to have that very clear. So CRH, ACTH, and then cortisol. So that's the positive feedback. If you have CRH, you will get ACTH. If you have ACTH, you will get cortisol. All right, so it goes 1, 2, 3. That's the green stuff. Now about the stuff here is the negative part of the axis. So if you are getting the cortisol is negatively going to feed back to both ACTH and CRH. So you see going back here, pretty much saying there's enough cortisol, you can stop now. And that stops production in the anterior pituitary and stops RH production in the hypothalamus. And that's pretty much the negative and positive feedback. That's everything you need to know really about the adrenal axis. So CRH, ACTH, cortisol, so it's plus and plus, and then cortisol says that's enough, stops ACTH, stops cortisol. Something to just keep in mind, which is not sure how important it might be for you, but this diurnal variation for cortisol. It's highest in the morning, usually least at night before you sleep. That's why it's called the stress hormone. It's also higher in infections, and an important point keep in mind. So you will need cortisol during an infection. If there's any question at all about this, just drop in the chat. And I'll keep referring back to the chat a couple slides. But drop any questions you have about this in the chat, and I'll get back to it. But that's the adrenal axis, and I really want you to fully understand it whatsoever. Just drop it in the chat. So now we're going to go for clinical vignettes. I don't want you to answer the vignette. Just read through it, have an idea of what the vignette is saying, and then we'll study very soon. So let's go with the first patient that we're seeing. It's a 38-year-old man who's presenting with increased fatigue and difficulty sleeping of the last few months. He has noticed significant weight gain mid and face, and he feels to come around. On clinical examination, he exhibits features suggestive of Cushing, which is central obesity, a buffalo hump, and thin skin with purple striae. Striae is just stretch marks. So in this whole vignette, keeping in mind, it's quite chronic. It's quite non-specific, as most endocrine disorders are. And it does have a few very noticeable features that kind of really jump out straight to you. And we'll leave that there. Then the second patient, 4-year-old woman, progressive weakness and severe fatigue over the last 6 months as well. It's chronic. Her skin is becoming darker, especially the creases of her palm, and she also reports dizzy and lightheadedness, particularly when she's standing up quickly. Right? So that's your first patient. That's the first and second patient, orthostatic hypotension with the standing up quickly. So let's start studying. So we're going to start with Cushing syndrome. All right, and we've got a picture here to kind of really accentuate all the things you're going to expect to see on a physical examination in Cushing syndrome. So in Cushing syndrome, have prolonged high levels of cortisol, and the prolonged high levels of cortisol bring about all these effects. Cortisol is the main stimulus by the adrenal gland. So it brings about all these effects that you're seeing here on the right. So the causes can be from a mnemonic cape. I believe there's another mnemonic as well that can help remember all the features, but they are quite pathognomonic, and once it's quite easy to remember. So you'll see obesity or weight gain, but that obesity is mainly going to be central, and you're going to be seeing it in the face and really the trap area where you're going to hump. So you're going to have really a proper hump in the back, as you would for a buffalo, which is where the name comes. And you'll see a very clear round face, very Cushing on appearance. And this, because it's quite rapid and it's a lot of fat that goes rapidly in the abdomen, it causes stretching the skin physiologically. This stretching of the skin results in stretch marks, and these are purple stretch marks. You can really see them as quite thick, and the skin feels very thin because of how rapidly they gain weight in the abdominal area. And these are already hallmark features that you will see in patients with Cushing syndrome. And as we mentioned earlier, there's other non-specific symptoms. You get insomnia, anxiety, depression, you get limb wasting, easy bruising, hirsutism. So in women's and here, let's see the other causes. So the cape. So because of Cushing syndrome, we've got disease. So I think very important thing to keep in mind, frequently in exams as well. So Cushing syndrome is the whole syndrome or the associations of signs and symptoms that we're seeing towards the right of the screen. Cushing's disease is a cause of Cushing syndrome. It's a pituitary adenoma that releases the excessive ACTH. And if you link that back to the adrenal axis we just saw, the excess ACTH is going to act directly on the adrenal gland and lead to excess production of cortisol. And because it's an adenoma, it's not dependent on stimulation. So just autonomously producing ACTH by itself, resulting in autonomous or unregulated production of cortisol. We've got adrenal adenoma as well, which is directly for downstream. The gland has an adenoma automatically producing cortisol, irrespective of ACTH and CRH levels. And you've got paraneoplastic syndrome, like small cell lung carcinoma producing ACTH from the cancer itself, exogenous steroids. So patients who are taking long-term steroids, they're potentially themselves with excess steroids, causing iatrogenic or Cushing's syndrome, as we just spoke about the right side. But I hope that really makes sense from the adrenal axis point of view, and it's going to be even more important in the guides. So when you have a patient that you're suspecting Cushing's syndrome, there's quite a few tests that you're going to. Usually in patients that they come straight to A&E, you'll almost always see a gas is already done, and you see a hypocalemic metabolic alkalosis in Cushing's syndrome. Now the confirmatory test, there's quite a few that you do, and we'll discuss a couple of them in detail. So you can do dexamethasone suppression test. It's something that's very important and quite foundational you can remember in endocrine, is if you expect a hormone level, like in Cushing's, you have high cortisol, there's excess cortisol, you will almost always do a suppression test, right? And in other syndromes, for example, Addison's, that we'll talk about soon, where you expect less cortisol, you do a stimulation test. So it's because cortisol is high, whether you can suppress it or not, which is why you do the dexamethasone suppression test. So talking about the dexamethasone suppression test, it's the first line test. And cortisol, how there's a diurnal so you'll see cortisol highest in the morning and lowest at night. These patients will not have their morning spike suppressed as you would expect if you gave them dexamethasone. So you're already giving them since you'd expect the body to react, not producing even more, but produces it anyway because there's also production of either ACTH or cortisol itself. So the 24-hour urinary free cortisol is pretty straightforward. It just sees how much cortisol your body is producing, and hence removing the salivary cortisol should normally be low. You're expecting it to be low. 9 a.m. cortisol, 9 a.m. and midnight ACTH. So if ACTH is suppressed, a non-ACTH dependent cause is likely, such as an adrenal adenoma. If ACTH is not suppressed, as you spoke earlier, you can expect, for example, Cushing's disease or ectopic production due to small cell lung carcinoma, which is the most common cause of ectopic ACTH production. A high dose dexamethasone suppression test. This is where slowly getting into the nitty-gritty. So we've already seen here dexamethasone suppression test. This is you do the lowest, you do a low dose dexamethasone suppression test as first line, and if you fail to suppress cortisol production, you then do the high dose dexamethasone test to help localize the pathology. And this really just depends on whether you can give enough steroids to suppress the ACTH levels or not. I won't talk too much about this. As I said, I want to really focus more on the basics. But what you should be keeping in mind for sure is low dose dexamethasone test is used as a first line test. And if this is positive, then you would go for a high dose dexamethasone suppression test to help localize the cause of your Cushing's syndrome. Okay? And it's not meant as high or low dose, you're going to assume that it's a low dose test. There's a few other tests that we do. Again, I don't want to get too much into the nitty-gritty of things, but what I'd really like to do from here is a gas sign, what you see on the gas is hypocalemic alkalosis. You have dexamethasone, there's two of them, and you will also check the urinary free cortisol to make sure that your body is actually producing excess cortisol. So once you do the high dose dexamethasone suppression test, you can see three results here. So you'll have your cortisol is suppressed or not suppressed. You'll have suppressed or not suppressed, and you'll have a combination. So if your cortisol is suppressed, cortisol is not suppressed, ACTH is suppressed, you'll be expecting something like an adrenal adenoma. You were able to suppress the ACTH, and you normally expect a lower ACTH in your axis means you're not gonna, there's no ACTH acting on your adrenal to produce the cortisol. If there's no ACTH acting on it, and the cortisol is still being produced, that means it's being produced by itself. It's autonomous production from the adrenal gland itself. So we always pretty much always go back here. I'll just jump back here. So if I'm stopping this, there's nothing going on from this side of things, but you're still getting cortisol. That means the adrenal gland is producing cortisol on its own. It's ACTH independent production, which means it's usually, if cortisol is suppressed and ACTH is also suppressed, that means by stopping that ACTH, you were able to stop the cortisol production, and that means what is accessed is the ACTH in adrenal adenoma. And if you're able to suppress either of them, then it's just ectopic ACTH. So it's not this ACTH. I mean, you weren't able to suppress ACTH at all because it's not the ACTH that's coming from, it's coming from somewhere else. And that's an ectopic ACTH syndrome. So carcinoma, things like that. A lot more rare, lot less likely to see, but definitely something to keep in mind. I hope that makes sense. I know this can be a little confusing here and there. Don't stress too much about it until you really get the foundations straight. Oh, there you go. So you can do other investigations, full blood count, usual bloods, CT tap leak is suspecting small cell cancer, and ectopic causes, MRI brain for adrenal adenoma, and then the treatment options pretty much are treating that underlying cause really. I hope that's clear. So depending on the underlying cause, you go for treatment options. But your I hope that at least the investigations and interpreting the investigations makes sense. Any questions so far? Let me just take a look at the chat. I was everything to silence, so I hope everything. I'm happy to go through it again, but if anyone, if you also want, there's a particular question, but you want me to go through any particular part of the data interpretation, again, I'm happy to do so. The data interpretation, I'd say, is one of the more important parts. As I said earlier, the axis really determines everything. So anything in particular everyone wanted to go over again, or we have it? If not, I'll be moving. That's it. All right, I'm done. So that was Cushing's in a nutshell. Now we're going to be talking about adrenal insufficiency. So there's multiple causes for adrenal insufficiency, as you can see them very clearly listed, of primary hypoadrenalism or primary adrenal insufficiency, and that's Addison's disease. It's almost destruction of the adrenal glands, leading to decreased cortisol and aldosterone production, and it's pretty much autoimmune. You've got secondary, which is due to inadequate ACTH. So once again, we're going back to our initial slide. Eating enough ACTH, you're not going to get enough of anything else that's being produced by the. And this can happen due to pituitary gland issues. So you usually have a pituitary adenoma, and the question stem that you really see over here is someone who comes with vision disturbances and non-specific symptoms. And you're really going to be suspecting secondary adrenalism. Sheehan syndrome is when patient is and they have a post, and this postpartum hemorrhage causes avascular necrosis of your pituitary gland, and it's obviously irreversible because it's pretty much dead in the pituitary gland, and this will cause secondary hypoadrenalism. Sheehan syndrome, something that you should definitely be aware of for your exams as well. Tertiary results from inadequate CRH release hypothalamus, and this can happen due to long-term steroid use, and which is why you also have to taper off your steroids slowly. So you'll see patients who are maybe on 40 milligrams, then go 35, 30, 25, 20, and so on. And this is to prevent tertiary adrenal insufficiency. Moving on to the next slide. So now we're moving on to the features. So you have the non-specific symptoms that we mentioned earlier, and hyperpigmentation of the palmaxes, and this is pretty pathognomonic for Addison's disease or adrenal insufficiency. And we've got the explanation here. The explanation isn't really high yield, but I guess helps you remember. So the large molecule that is product ACTH is derived from is cleaved. Also produces melanocyte stimulating hormone, and this then usually have high ACTH because, going back to the slide yet again, enough cortisol is not having enough negative feedback. So there's no negative feedback. There is unopposed stimulation of your CRH and your ACTH. I hope that makes sense. So I just going back to our first. Just put it here so it's easier. Going back to our first slide here, your CRH is producing, your hypothalamus is producing CRH. That's making the to produce ACTH, and that's producing cortisol, which provides negative feedback. However, there is no cortisol being produced here, so there's no negative feedback. So your hypothalamus is just producing more CRH, and that's just telling the pituitary to produce even more ACTH. Still no negative feedback. And then you end up in the cycle of you just saying like a proper excess of CRH and ACTH. Now, because you're producing so much ACTH, you're cleaving so much POMC, and because you're cleaving it so much, you produce so much excess ACTH, you're having more MSH producing inside stimulating hormone, which is why you're having hypertension. I hope that now is a little more clear. Right? It's because you need to produce so much ACTH, just producing because there's not enough cortisol, that you're having these adverse effects that you normally wouldn't have. So I hope that makes it more clear. Once again, any questions? I understand mind a little bit. So any questions, just drop it in the chat. We'll get to it very soon. It can cause postural hypertension. That's again because of the lack of steroids. And if you say a little bit about postural hyperactivity, we do refractory postural hypertension. We actually prescribe steroids, so that will really help you put two together. This can send you into a crisis while during times of stress or infections, because again, as you recall, cortisol is a stress hormone. Over here, you don't have an cortisol, so during stress, it's even worse. Hypoglycemia, hyponatremia, hyperkalemia, vitiligo, usually fatigue, weakness, and usually a condition related to women. So the first line is ACTH stimulation test. Once again, over here, cortisol is too low. Something is low. What do we do in endocrinology? We just try to make it high. So we're going to try and do a stimulation test. So first, you get a baseline measurement of the cortisol level, usually at 8 a.m. Why? Because the highest, right? We said there's a diurnal variation of cortisol in the morning, tells you to wake up. Lowest in the night when it wants you to sleep. It's a stress hormone. So when you wake up, you want to really get going. When it's time to sleep, your body just relax. No stress, low cortisol. Okay, so you see what your baseline cortisol is. Then you give synaxin, which is ACTH. And then you see what happens. Again, if you remember what happens when you give ACTH, you expect your adrenal gland to produce cortisol, right? So ACTH and cortisol comes back. It's part of the initial diagram. Addison's disease or primary adrenal insufficiency, there is an inadequate response because the antibodies have already destroyed your adrenal gland. So there's nothing that the AC, which is why you don't get any stimulation from it. Usually, people don't jump to an ACTH stimulation test, even though it's the ideal first line. Sometimes you do a 9 a.m. cortisol to rule it out. So it's not specific; it's sensitive. So if your cortisol is over 500 in the morning, Addison's is very likely because you're clearly producing a cortisol. If it's less than, then there's something definitely going on because you're not producing enough cortisol. But the issue is it usually ends up in this range. Basically means we don't know whether it's high enough, just a complete gray area, which is why ACTH stimulation test is actually a first time. It's going to tell you yes and no. Whereas this usually just tells you maybe. I hope that, I know it's very crude to explain, but I hope it makes more sense. So above 500, below 100, and actually 9 a.m. we expect it to be the highest. And ACTH stimulation test is the first line. You expect cortisol to be low, you do a stimulation test. That's how endocrinology works. So you're going to see a few abnormalities. You see metabolic acids with hyperkalemia. And if you remember earlier, we spoke about Cushing's. We said metabolic alkalosis with hypokalemia. So they're the exact opposite things. Too much cortisol, too little cortisol, exact opposite ABG, or ABG as well. Should make it a lot easier to remember. Again, treatment and underlying cause. Further investigations are pretty much based on what you're suspecting. So if patient has Addison's, which is primary adrenal insufficiency, you're going to give them the steroids they need. The steroids are, mineralocorticosteroids and this is cortisol. So you give cortisone and you give fludrocortisone to the patients. The doses aren't really important, especially for patients, but just to know that you have to replace both for such patients. Would be similar in Sheehan syndrome as well, because you don't have to have a pituitary. And this would be a very, very important part, very important to remember. It's an Addisonian crisis, right? So this is a severe form of adrenal insufficiency, which is exacerbated usually due to a precipitating factor, which is usually again an infection. So severe adrenal insufficiency, you have patients who can come in refractory hypertension. Very important to remember, hypernatremic, hyperkalemic. It's usually sepsis or other causes of stress like surgeries. And these patients, again, for all of us, when we have infections, our cortisol is going to shoot up to help defection, prevent hypoglycemia, help keep up blood pressure, and everything between. In such patients, you don't have any cortisol that's helping, and it really pushes them over the edge, resulting in Addisonian crisis is a medical emergency. You are going to give them hydrocortisone, VRIM, 100 milligrams. They're usually seen in resus, they call ambulance, and they usually are, when they're coming to hospital, they obviously have a surgery at home. So they're usually coming septic. So you'll see a patient who's septic, refractory hypertension, hyperkalemic, can't understand why, it's usually an Addisonian crisis. And you see, they come to research endocrine, treat the infection and send them home with replacement. Any questions so far? So that's Cushing's and its essence. Keeping an eye on the promise, I'll do my best to be finished on time. Any questions at all? I could not hear you during the explanation. Of course, the explanation of which part, actually. Yeah, I'm sorry about this sound. I'll try to, at least for the next session, try to figure it out better. Just another quick test on the sound. Does this make sense versus this? Or are the the exact same? Is it any better now, the sound-wise? It's pretty much the same. And if you could just be clear on the explanation of which part, would you like me to repeat? I'm happy to repeat it. Or if you just let me know which part. I'm just going to change it back in case you hear me. Could you hear me when I was speaking earlier? Yeah. Melanocyte or hypertension, I could not hear very clearly. Okay, I'm going to go back to the earlier setting. I'm just going to speak louder and go over it again, okay? Just go back and back. There we go. All right. So in Addis disease, I said this is pathognomonic, which pretty much means if you're reading a question and the question says hyperpigmentation of the creases, you forget about reading the rest of the questions and click on the answer that says Addison's. All right, so that's important to remember this. And if you like to think in a logical manner, I can explain to you why this happens, right? So what the main thing you need to remember is over here you see POMC. You keep POMC to produce H. So it has ACTH here and it has melanocyte stimulating hormone or MSH, and this is what is causing the hyperpigmentation. But why is this happening only in Addison's and not all the time would be the question that you need to be asking, right? So talking about once again, the all-important slide, talking about the axis. We said CRH here makes more ACTH. ACTH here goes to the adrenal gland and makes cortisol, and cortisol basically says, okay, I'm here, stop producing both of them. And then you get less ACTH and less CRH. In Addison's disease, it is deficiency of cortisol, right? Because of autoimmune destruction of the adrenal gland. So there's just no adrenal anymore. Like, this is pretty much not there. So you can't produce enough cortisol. I mean, it's there, but even. So your hypothalamus is producing CRH, and your pituitary is saying, I'm producing more ACTH. And they both, the CRH and ACTH, are just waiting for cortisol to say stop. But in Addison's, there isn't enough cortisol production, so there isn't any negative feedback. So your hypothalamus produces even more CRH, and then that produces anterior pituitary produces even more ACTH, and they're still waiting for a response, and they increase and increase and increase, and you end up in this cycle where you obviously have a huge amount of ACTH in the body trying to stimulate this adrenal gland. Now, where did ACTH come from? By this slide, from POMC. Because you're producing so much ACTH, you're also producing so much MSH. And because you're producing a lot of MSH, it's causing hyperpigmentation. Does that make sense? All right. I assume that makes sense. I think that was, but I hope that makes sense. I hope my voice was better. I hope I was louder. But that's pretty much the hyperpigmentation. So just really important to keep in mind for Addison's. So just moving back to the clinical vignette. I actually prepared like, you go poll. Let's see if I can make this work. Start polling. There you go. So what do you think our first patient has? The 30 years pretty much in the answer, actually. But that's the first patient got Cushing's. You can really tell from the pathognomonic, buffalo hump, central obesity, striae, and the round face. All right. And the second patient, weakness, fatigue. You can't really tell what's happening. And then they tell you, oh, she's a middle-aged woman actually, and she's got darker skin in the creases of her palms. You don't have to really read anything else. She's got Addison's. And the stimulation tester, okay? So now, on, be a bit faster. So here's a second clinical vignette. A patient has been referred from their GP for suspected secondary hypertension. It's a 45-year-old man. He's got episodic headaches, palpitation, and profuse sweating. These are three things, again, really try to remember this. He's got headaches, he's got palpitations, and he's got the most important part of this question is it's intermittent, which means it comes and, okay? No weight loss, no family history. His vitals are even normal during the examination. And we don't think the patient's lying, obviously. So what causes episodic headaches, episodic palpitations, episodic sweating? It's nothing that we already learned. It's a pheochromocytoma. So again, a very, very interesting diagnosis. You'd make very rare as well, but very high yield for medical school examinations. The catecholamine secreting tumor of the adrenal glands, which is basically adrenaline and non-adrenaline. There is a 10% rule. It's a bit outdated now, but it's something. 10% are bilateral, 10% are cancerous, and 10% are outside the adrenal gland. So pheochromocytoma is a tumor of the adrenal gland, which is secreting catecholamines. And it results in episodic symptoms, right? So you get episodic hypertension, where patients go into hypertensive emergency, like 200 systolic, and they come back down to normal blood pressure. They get these episodic headaches, palpitation, sweating, and anxiety with it, because they just so much adrenaline pumped. So normally you get these in patients, not patients, in times where you require excess cortisol, excess sympathetic stimulation. You might have this when you're going to write an exam, or when you're standing outside the OSCE station, or when you're outside and you're scared. Actually, you would also have these symptoms. You would have a slightly high blood pressure, you're going to have some palpitation, you're going to have some sweating, some anxiety, and that's normal. But for these patients, they'll be sitting and watching television, or just sitting and studying, and get these things out of the blue, which is obviously very, very. They might even say, "I feel like I was going to die," and it just comes and goes. Okay. So the investigation of choice is 24-hour urine collection of methamphetamines, which are the byproducts of the catecholamines. So you pretty much do this test, and it says, oh yes, this person over the course of the day has produced more catecholamines than they normally should have. You can do CT/MRI to look for the tumor, and as I said, 10% of them might not even be the adrenal gland. So usually you do have to do imaging in such patients, and again figure out where exactly it is. Treatment is always definitely research. You need to stabilize these patients. They can be quite unstable. Something that is ideal in such patients is giving a beta blocker first is going to lead to a hypertensive crisis and a cardiovascular collapse. This patient is going to die. Okay, you cannot give a beta blocker first in such a patient. You have to give an alpha blocker first, and usually you give fluoxetine. And the answer is basically because if so beta blockers, there's a few reasons. The first one is it prevents vasodilation, and alpha is going to cause worse vasoconstriction. So if you give a beta blocker, you first of all not going to let the blood vessels dilate, let blood pool, which would effectively lower blood pressure or not increase it too much. If you prevent your blood vessels from really vasodilating, and you immediately contract them, it's going to lead to a hypertensive crisis. You're going to just make everything so much worse. The blood has less volume to roam, less place that it can roam, same volume, and hence it just increase the high blood pressure. Beta blockers also cause reflex tachycardia, which is going to worsen the heart rate and cardiac output, once again increasing the blood pressure. And because of this, it's going to lead, and because you're blocking all the beta receptors, all the catecholamines you're producing are immediately going to bind to the receptors, and this is just going to cause extreme vasoconstriction, and this patient is going to end up with a hypertensive crisis. They're going to have endocrine damage. They might even be in front of you. So very, very, very important. Patients with pheochromocytoma, never beta blockers. You're always going to give alpha blocks. All right. After you give alpha blockers, you give beta blockers. Any questions now? We should on time. Oh, it's frozen. Unfortunate. When did it freeze? Is it still frozen? Yeah, I don't think it is. At least not for me. I'm on the any questions slide. Not frozen as in, right? Okay, then I'm going to be moving on to the, it's okay now, perfect. Moving on to our last clinical vignette. So a patient has been referred by the GP once again for the clinical vignette again, sorry. So pretty much in this vignette, you see episodic, that already raised in your mind, hypertension, that's episodic, then, and which is associated with headaches, palpitation, and sweating. You pretty much know this patient has a pheochromocytoma. You're going to give an alpha blocker. You're not going to give a beta blocker first. You can give that afterwards. Once the patient is stable, you're going to investigate them. You're going to get 24-hour urinary methamphetamines, do imaging, and you're going to refer them for surgery. All right, so pretty straightforward case if you understand what you're doing. And here's our last case, which is a patient coming for generalized weakness. He's got polyuria, lethargy, muscle weakness, and nocturia, which is passing urine at night. He's got high blood pressure. He's got a high-ish sodium, a pretty low potassium. All right. Here we're suspecting Conn's syndrome, which I've already put as part of the vignette. And the Conn's syndrome is basically mineralocorticoid excess in patients. It's not cortisol excess, which is Cushing. It is mineralocorticoid excess, which is Conn's syndrome. And the investigations for this are, the first line investigation for any hypertension to begin with is renin-angiotensin ratio. And in a patient with Conn's syndrome, the angiotensin ratio is going to be high. You're going to do a salt loading test. And normally, if you give enough salt, you're going to push the aldosterone down. It does not get suppressed. And then you do CT adrenal to find the cause of Conn's syndrome, which is usually bilateral adrenal hyperplasia versus adrenal adenoma. So CT adrenal will either tell you it is hyperplasia or adenoma. If your CT adrenal is inconclusive, you can do a more invasive investigation, which is adrenal vein sampling. So direct the adrenal vein, you test the blood and see where your excess mineralocorticoids are coming from. Once you find out where this is coming from and what the issue is that is causing Conn's syndrome, you then either opt for surgery if it's an adenoma. If it's bilateral hyper, you can't remove adrenal glands, so you give mineralocorticoid receptor antagonists usually long, and you titrate it to effectively treat the symptoms of the patient. I haven't gone too deep into Conn's syndrome, and I haven't gone too deep into phemocytoma because these aren't as relevant to the UKMLA curriculum as Addison's and are. I hope at least the main thing I want to be very clear is the adrenal axis. As you can tell, this is pretty much the absolute foundation for you to really understand what's happening in Addison's, what's happening in Cushing's. You need to know this like the back of your palm. So I really would hope that this at least is pretty much rock solid, clear in your mind. Remember this image for Cushing's syndrome. Try to remember this and understand. We don't even remember, really understand this. Once you've properly how Cushing's is caused and what really is going on, then for adrenal insufficiency and Addison's, keep in mind documentation. The explanation isn't as important. It's just something to help this hyperpregnetion stick in your mind. Keep in mind that only primary adrenal insufficiency Addison's, you can have secondary causes like Sheehan syndrome and pituitary adenomas in such patients. You can also have like adrenal insufficiency for patients who don't taper off of long-term steroids, or pretty much who don't taper off of long-term. As with most things endocrine, treatment is based on underlying cause. And if you remember the causes and you can identify, you can very easily identify treatments of that. Is it's episodic, and maybe Conn's syndrome, the main thing you should remember is hypokalemia and high sodium. We don't have enough time to really explain what happens. It's the mineralocorticoids that really pull into the body, causing so the water follows the sodium, so it's pulling sodium in, pushing your appetite, and that's causing the blood pressure and hypokalemia. And that's what really is caused in Conn's syndrome. How that makes, so sorry about the technical difficulty I had earlier, but hopefully it's better now, and I'll try to fix the static that you've been having to sit through for the session. Thank you everyone for attending. Our next session is going to be on diabetes. We're going to do a part 1 and part 2 of diabetes, really go through what causes it, the treatment of it, and the complications of diabetes, both type 1 and type 2 diabetes mellitus. And we've also got a session on the pituitary itself that we're all working on. So do come for that. As usual, we'll send the message for it as well. I'd really appreciate if you could fill the feedback form, and I'm wait for the 5-10 minutes to really leave, just in case you have any questions. I'm happy to go over anything, so do let me know if there's anything that you'd like me to go through. and thank you for coming. Thank you. All right, guys. If there's no questions, I'll be leaving the leaving the session. So last chance. Any questions at all? All right. Once again, everyone, thank you for attending. Bye.